Well, good afternoon, everyone, and thank you for joining us today. I appreciate for members, this is the middle of the pharmacy day, and so you might be watching this on catch up rather than joining us live. I have to say, I did toy with the idea of introducing our session today with a few bars of Sweet Caroline after last night's amazing football win, I think, for England. Yeah, I'm not giving too much away to say I was just one the last time England played in the final of a major football tournament, so I've got literally no memories of any of that. Unfortunately, though, I couldn't quite think of a link to our headline sponsors, to Lifebuoy. No doubt they'll fill me in afterwards on quite how we could have linked to Neil Diamond. But thank you to Lifebuoy and to Unilever for supporting all of the events this week. We're really pleased to be working with you. However, in some ways, that introduction would have been fitting for our speaker today. Our speaker today is very much a key player in the England team, the NHS England team. I'm delighted to say we're joined by Ed Waller, and you can see Ed on screen with us now. Ed is Director of Primary Care at NHS England. Now, Ed arrived in this role, or a version of this role, about 3 years ago. And ever since I first met Ed, it seems the scope of what he's managing and the size of his team just keeps expanding. He looks after the pharmacy contract, of course, and the GP contract. So we thought Ed is in an ideal position to talk to us today about integration and how he sees community pharmacy fitting in with that changing NHS landscape. Now, some of you will know that towards the end of 2020, Ed was asked to lead on the planning for the COVID vaccination strategy and formally park his day job for a few months. All of that still sits under Ed's control, but unfortunately now does have someone else to lead on that for him. Some of you may also know that Ed reports into Ian Dodge. Ian is head of strategy and also an NHS England board member. And Ian, in turn, reports to Simon Stevens, the soon-to-be departing chief executive. So you can see Ed's role is a very central job in the England team there. It's a big job. What you probably don't know, and I think Ed, perhaps likes to keep some of these things to himself, is that Ed also has 3 children, one of whom is under 5. And I know exactly how difficult it has been for all of my team at the NPA, working through juggling childcare over the last year while still performing in a job. Somehow Ed has managed to do all of that alongside a huge job helping the country cope with the pandemic. So thank you for that, Ed, and well done. So with all of that context, we're really pleased that Ed has found half an hour to join us today. I think he's going to talk for maybe about half that time and then take some questions from members at the end. Ed, over to you.
Thank you, Mark. It's a very kind introduction. And I knew you would manage to make a football link somehow. So if I start with the first slide, we can pop that up on the screen. I don't know if that, unless you can all see it and I can't.
It's up there, Ed, you're good.
Oh, is it? Fine. If we start with the first one, I think the first thing that we wanted to do is just to say thank you. So it really has been an interesting 18 months for community pharmacy, but also for the whole NHS. But I've been incredibly proud and amazed about how far community pharmacy has been able to keep the show on the road, as they say, to keep supplying patients their medicines, to keep delivering clinical services, keep the staff and patients safe, and even to do more. So to introduce new clinical services through the framework, which is the GP community pharmacist consultation service and the discharge medicine service, and services around the pandemic, like the medicines delivery work that you've done and what you've done around the provision of testing kits. So I just want to say thank you for that. And in particular, as Mark says, for about 6 months of my life, I was involved in setting up the primary care part of the COVID vaccination program. We've got 650 pharmacy-led vaccination sites now, pharmacies are going to be delivering an increasing proportion of vaccination for COVID. And you've played a huge role, those of you who are part of that, in 45 million people getting a first jab and 33 million having their second. So that has been an amazing effort. And the sort of flexibility and the can-do attitude that people have brought to that program has been incredible. So it's only with all of that as context I'm going to talk about the future. I think it's fair to say that some of the things that all of us would have planned might otherwise have happened over the last 18 months have been a little bit derailed by COVID. I guess at work and at home and in every respect. But we have a 5-year contract deal, as you know, for the future of the sector. And what I'm going to set out a little bit is what happens next and what you should expect. So we can move on to the next slide. I hope this one's got an inverted triangle on it. The other thing that we've got to...
just a second, Ed. Oh, there we go. There we go. You're on.
Yeah. The other thing we've got to recognise is that we're coming back, you know, in some respects from the COVID pandemic, although it hasn't gone away, to a world that will look different since the publication of the health bill this week. It will change fundamentally and sort of permanently the landscape in which we all work. It will establish ICSs formally as part of the NHS system. And so community pharmacy, but also the wider pharmacy workforce and will be affected by that. So you'll have community pharmacies working within primary care networks who will be working across a place, say a town or a city, but be part of an integrated care system. And I'll talk a little bit about how we might go about approaching what we should decide nationally and how some of that new local landscape should impact on what community pharmacy does and how it happens. If we can move on to the next slide. The key components of the role of community pharmacy in the future are laid out on this slide as far as we see them. So we've done an enormous amount, all of us, to create a more formal role for community pharmacy in the urgent care and access system. So we've had an incredibly successful implementation of CPCS referrals from 111 in particular. Over 400,000 people referred into community pharmacy since that service started. But we know that that's the tip of the iceberg in a sense of what we can do on urgent care, minor illness, urgent medicine supply in community pharmacy. And over the next year or so, we really, all of us, need to think about everything that we can do to make the most of the GP version of that scheme. And we are working with general practice to make sure GP surgeries are understanding that service and starting to refer through it to community pharmacies. I know that you'll be doing that locally with your GP teams. Perhaps one of the things we'll pick up in the questions is what more can we do to build that in as a fundamental and standard part of the way we direct people to the right place for their needs in primary care. But we also know you're already playing a big role in self-care and in minor illness outside of that CPCS. We know that in order to make the new ICS PCN architecture work, we really need to optimize things like access to care records to support clinical service delivery across primary care. So that's something we're actively working on, and the interoperability of systems to make data transfer efficient. That, for example, would unlock, which we're also working on, some of the GP to pharmacy referrals, I think, and to make sure that we're harnessing some of the technology that actually got rolled out at an accelerated pace across the COVID pandemic. One of the things that we might be able to keep that might have been a positive of that period is the extent to which we've worked out what is good and what is complicated about using online and remote consultation. We know that community pharmacy's got a massive role in prevention. So a lot of the things that we talked about in the 5-year contract deal for the sector was about detecting diseases like hepatitis C, the role in vaccination, which community pharmacy did a massively larger number this season of flu vaccines than they did last year. And obviously I've talked about COVID vaccination. Cardiovascular disease, a big priority for us talked about significantly in the long-term plan. Community pharmacies, we think, are really well placed in the community to help us find some of the undiagnosed cardiovascular disease that's out there and to help us bring people onto treatment and monitoring. We also want involvement in obesity, contraception, and helping people to stop smoking. On the workforce side, there are some really significant proposals around how we might change and adapt the training pathways to, as you know, produce pharmacists who are prescribers as they leave the training pathway. We want to think about how we can make the additional roles scheme in general practice in PCNs work so that pharmacists can have a mixed career working across community pharmacy as part of PCNs, potentially even community pharmacy providers ending up as the provider of some of that pharmacist workforce PCNs as part of building really close alliances with general practice. So there are lots of things going on around workforce development. I'll talk about clinical leadership in a moment. And of course, at the core, always will be the community pharmacy role because of the supply of medicines and their optimization and safety. So new medicine service, the discharge medicine service that we've rolled out, some of the work we do on quality, all of those will continue to be a core part of what community pharmacy is here for. If we can move on to ICSs, some of what we hope ICSs will deliver. Sorry, if we can move on to the next slide, that wasn't clear. ICSs are about how we use financial resources, how we improve and transform the way we buy care and deliver care. It's about improving the collective accountability in systems. We want people to feel like they're part of a system, delivering with colleagues, and because of that, to do joint workforce planning, have better input into commissioning, and in scenarios that we've just experienced, join up their emergency planning and response when it's most needed. And also to have a joint infrastructure around things like digital, data transfer, etc., that will serve patients better. And in most places, ICS is being set up on local authority boundaries and are delivering some of the things that are on this slide. I think the key question is what this means for community pharmacy if we move on to the next slide. I think the first thing that I want to continue to emphasize is we really want to see community pharmacy a more and more integrated part of every primary care network. So I know that is working better in some places than others, but I've heard some really encouraging examples of how community pharmacy and general practice have worked together on COVID vaccination, on flu vaccination, on the management of various conditions. And I know that in other places, the relationship isn't as well developed. But for things like the GP referral route through to CPCS to work well, I think it all hinges on those relationships at a local level. We also need to get the clinical leadership within ICSs right. So part of that clinical leadership can be built by those good PCN relationships, that involvement of community pharmacy in PCNs, and PCNs acting as a conduit for the perspectives of primary care to be taken account of in ICSs. But we'll expect ICSs to have mechanisms to involve people from a clinical perspective across the different professions and settings, so that they really are taking account of the different views, expertise, experiences to design and deliver services better. You'll also probably have realised that the new bill allows the commissioning of community pharmacy services explicitly to be delegated to ICSs. So obviously that means that it will be possible to build a stronger local commissioning framework through ICSs for community pharmacy. We will have a national contract, but I think there are some huge opportunities in a greater degree of local commissioning input to make community pharmacy a more integrated part of the NHS. And I think one of the things I've noticed over the pandemic is that community pharmacy was thought of as a place to deliver COVID vaccinations, to make sure people were getting their test kits, etc. And it was thought of as an integrated part of the NHS in perhaps a way that it wasn't in the past, and a way that I'd like it to be more thought of in the future. I think that's all I wanted to say, Mark. I think that's about half the time, and I think the important thing really is to hear from your audience and have a discussion about some of those issues and what some of the opportunities ahead might be.
That's really spot on timing wise, I think, Ed. It's excellent. And while I'm looking for a few questions starting to come through from members, perhaps I could kick off and ask you one from myself, really. So I suppose the first thing to say on behalf of members is always thank you for recognising all that value that pharmacies have provided, continue to provide during the pandemic. I know members put a lot of store by that, and at times I don't think they've always felt that's the case. So that's really, really important to hear you at the top of the tree saying that, Ed. Thanks for that. And it actually reminded me of a conversation I was having recently with Harry McQuillan, who you may know. Harry is the Chief Executive of Community Pharmacy Scotland. And one of the things Harry was saying to me was that during as a result of the pandemic, he believes that the kind of standing of community pharmacy has really been enhanced across Scottish Government and the various NHS boards throughout Scotland. And he said, I'm getting invited to meetings that I didn't used to get invited to. Doors were opening that weren't there before because of that recognition. And they're part of planning a future now that they weren't previously part of in Scotland. Do you think, from your perspective here in England, do you think that's true in England too?
I think that is true in England. So I think, for example, the testing rollout, ticket kind of distribution rollout, the critical role community pharmacy played on the COVID vaccination programme, ministers actively talking about community pharmacy playing a bigger role. I think it's really clear that there is a consensus that community pharmacy has got more to offer. The fact that some of the things that the NHS talked about in its long-term plan as priorities, like detection of undiagnosed CVD, the fact that we're talking with all of the teams that lead on that about how community pharmacy plays a massive role in delivering that shows that people are thinking about community pharmacy. And I think my request in return as part of strengthening that is just that people grasp those opportunities to be a part of some of the core priorities of what the NHS is trying to do, and make the best of those. Because if we can show that community pharmacy can play that role in CVD detection or in the vaccine rollout programme, then it's a great base from which to do more.
Yeah, I mean, as always, success breeds success, doesn't it? Really, being recognised to do something well. And I mean, that links in a way, Ed, and you mentioned it in your speech there. We're halfway through the 5-year CPCF, the 5-year deal in England, and you acknowledge that we're not as far advanced with delivering all those new services that we set out, the framework set out at the start. Obviously, the pandemic is a big part of that, but I suspect members would say it's not the only part. It's not the only reason for that. There's that recognition that landing some of these services, particularly something like GP CPCS, is complex because there are multiple different levers there in the landscape, and many of them are not just not in control, but sometimes they're not even easy for community pharmacies to influence, let alone control. And again, I'm reminded of that really famous Bill Gates phrase, I think, which we tend to overestimate the change that will happen in 2 years, and we tend to underestimate the change that happens in 10 years. And so I don't want to be part of that sort of mindset that is trying to see things happen too quickly. On the other hand, I don't want us to fall short of doing all the things that we can do to make these things happen, and so that you see that bigger change over the longer period. And I think the NPA is wholly committed to supporting our members and the sector in meeting those needs that the NHS is expressing. Could I ask you, as a commissioner, as the sort of customer ultimately, Ed, what do you think we can do better together to make some of those things happen quicker and accelerate the uptake of some of these services? GP-CPCS being a good example, I guess.
Yeah. So, and it's interesting because if you look at, for example, the rollout of flu vaccination in community pharmacy over the years, I think I'm right in saying in 2015, 16, there were about 500,000 flu vaccines delivered in community pharmacy. And this year we saw over 2.5 million flu vaccinations delivered. And it has been a steady rise. So I think, as you say, we shouldn't expect all of these things to happen magically overnight. But we need to think about all the things we can do to make that happen as quickly as possible. I think there is a heavy dose of relationships in here. So when I've been to see the people who've made the best success so far of GP-CPCS, CPCS, it's a good tongue twister. When you sit in a room and listen to them talk about what happened, it was partly about having some time and resources to think about it carefully, but it was also fundamentally about the trust between the practice and the pharmacy, and getting to a point in their relationship where that felt like a natural thing to do as a collaborative service delivery approach. So I think some of this is unlocked by really good relationships locally through PCNs. Some of it is unlocked by us thinking about the technology we're using to make sure that, for example, referrals are as automated as they can be, so that fewer people need to be persuaded that something needs to be built into the way they work, and to sort of make that happen. The more automated you can make things, the easier you can make the click through to send somebody to a community pharmacy instead of bring them into an appointment in the practice, the more likely it is that that will happen. So we're working on all of that. And we do need to build awareness of some of the services, frankly, in places where, as in community pharmacy, people have been so busy in the last 18 months, they've had so many things to get their head around and to prioritise. They haven't always been able to understand exactly what's on offer from community pharmacy and to connect with it in the right way. So anything LPCs and the NPA and individual pharmacies can do to make that happen locally, I think all for the better.
Yes, I think that's right, isn't it, Ed? And I'm also aware, listening to members, that people will sometimes say to me, it's very different. You know, there's a responsibility on their part to commit to this agenda as well, and it's sometimes quite hard to do that when around you're very aware that the services aren't coming, the referrals perhaps aren't coming through at the moment in any volumes that are going to kind of even register on the costs of running a pharmacy each week or each month, and that in itself is you're sort of betwixt and between, aren't you, really? And the reality for all pharmacies, I think, is the majority of funds to cover their costs still come from dispensing. And, I think the NPA's line has always been, we need to be funded fairly to cover the dispensing costs, but also to cover those emerging clinical services. What thoughts, could I ask you what thoughts you and the wider NHS and the department have given to how you might encourage, support those changes? Would you perhaps consider both the level of funding and even the way in which you fund pharmacy to incentivise those changes? Is there more you can do in that regard?
So I think I'll be a bit careful because I have to make sure I don't stray into the territory covered by the contract negotiations. But
absolutely.
The contractual framework is clearly set up in a sort of a long-standing way to deal with the costs around dispensing. One of the features of the framework for the first part of this 5-year deal was to create something called the transition fund, which was designed to try and create some money attached to the difficult period that you described, where you would be between a business model almost entirely focused on dispensing and one in which there was a greater dose of clinical services. So we accept that is a tricky transition to make. And it's particularly tricky for services where, as you say, you're not wholly in control of the volumes.
Mm-hmm.
But there are in the mix for the 5-year deal in the document that was agreed at the beginning, a set of things that are that kind of slightly harder to predict at the beginning, certainly of a rollout in terms of volume. And there are some services like CVD detection, which will be much more in the hands of community pharmacy to control and to deliver proactively, and to make sure that they can, create the stream of income and an outcome for patients that we're after. So I think it's about having the right mix of those things, and we're obviously keen to get on with implementing as many of those clinical services as possible to try and diversify them, because that in itself will create a mix which will, I think, support some of the issues you're describing.
Yes, and that sounds very sensible, Ed. I think possibly one of the challenges, as you say, is the initial services in this 5-year framework were very much things that weren't easily influenced or controlled by individual pharmacies, at least, and getting a better mix there. And you talked about the flu vaccinations and the COVID vaccinations. They're things that people have been able to, largely bring their can-do attitude to bear on, which I think is perhaps where the sector's flourished. I'm conscious we've got a couple minutes of your time left, and maybe ask you one last question. And this again is something that members talk to me about as a worry. I think sometimes there's a skepticism that the NHS, the ICS framework will just be a new fashion for a few years. And I guess that's true in many sectors, that potential change of language and change of structure. But I wouldn't want that to get in the way of some of the fundamental changes you're seeking there. I often hear from members they're worried that they might be overlooked or not involved or not visible in some of the changes and some of the decisions that are made locally that you were setting out there. And with somebody in your role where you're responsible for the whole of primary care and the strategy around that, what could you do from the centre? What can you do from the centre to ensure that community pharmacy isn't forgotten in those structures and in all the different structures? It's not a question of having a place on the board. I think it's more all of those different ways that ICSs will work in the future. What can you do from the centre to enable that community pharmacy gets an appropriate place in there and an appropriate recognition?
So I think from my perspective, what I see my role as doing is helping to create the expectation in the way we describe the new way of doing things, that different professions in different settings will have a role in providing their perspective on the key questions for the system, and that there's an effective mechanism, and it doesn't have to look the same everywhere, but there's an effective mechanism to garner those views, to channel them effectively, to allow discussion, etc. I think what's important is we don't think about this necessarily as about representation, because it's not. ICSs are not really. We're not really trying to seek new mechanisms for representation here. We're thinking about the clinical perspectives and service delivery perspectives in particular. And I guess my reflection from some of the work I've done in the past on new models of care and other things is the more primary care as a whole, frankly, but even community pharmacy.
You were midway through suggesting to us that we shouldn't think of this as about representation. This is about how clinical services are organised, and then we lost you.
So I think really, in my experience of working on new projects around new models of care and in primary care, I think primary care as a whole has the best influence when it can agree between all the providers in primary care, not just community pharmacy, but general practice and others, what it wants to see happen in a system and what it thinks the priorities are, there will be community pharmacy specific issues, but even then, community pharmacy talking with one persuasive voice about what it thinks the right answer is always going to be more powerful. So I think the kind of counter to having a system which is built in a way to harness the views of community pharmacy is to think about how community pharmacy in a place or in a system can contribute views that are as one and are as constructive as possible for people at the other end to receive and do something with. Because I know from experience that what's always hard if you're trying to run a system or you're working in an acute trust where you've got hundreds of GPs and pharmacies you're trying to engage with to make systems work is a different set of views about what the future should hold, because it's very hard to know how to reconcile them. I think that's the challenge on both sides, to build systems to get the views and then make sure the views are kind of unified and constructive as they can be. And
that I think, Ed, is a fantastic challenge to us as a sector to end the questions on there. It's clearly there's a lot you can do in the centre, but there's also a lot the sector can do itself to enable that future in as effective a way as possible. So Ed, all that remains really, I'm conscious of your time and your next meeting. Thank you so much for taking the time out. We always appreciate it. We'll let you know quite how many hundreds of people see the video as it goes forward. I think there's one of the things we've realised this week is there's a massive move from watching stuff live to watching stuff recorded, which I guess just reflects the way society takes in a lot of media these days. That live isn't always the most popular part of it. So thank you again, Ed. Really great to have you. Have a good afternoon.
Thank you, and you. Enjoy the conference.